Morning, everybody. There you go. A second here. Right. All right. How's everybody?
Great. How are you this morning?
Well, thank you. Okay, so let's get moving, I guess. So we're going to finish up the talk that we started last week. This is the basics of electrophysiology. So we ended with this slide, and I'll remind you that when we think about the heart, again, when I'm looking at an EKG or thinking about a management or evaluation of an arrhythmia, I'm thinking about the level of the heart, and I work my way down from the top to the bottom. And remember that there are two major mechanisms for arrhythmia, being automaticity and that of reentry. And again, at the level of the sinus node, we have sinus tachycardia is the most common automatic arrhythmia, if you want to think of it that way, and sinus node reentry, a much more rare, but still occasionally seen reentrant arrhythmia at that level. At the level of the atrial muscle, automatic arrhythmias specifically are ectopic atrial tachycardia or multifocal atrial tachycardia, again, sometimes called chaotic atrial rhythm. And then, of course, atrial flutter and atrial fib are both reentrant arrhythmias from the atrial muscle. At the level of the AV node and the His-Purkinje system, JET is the most common automatic arrhythmia. And, of course, AV nodal reentrant tachycardia is the more common reentrant arrhythmia. In terms of AV reciprocating arrhythmias, there is no such automatic one, although I guess you could say a Maheim fiber sometimes has its own automaticity. And then, so I'll change that. I've been writing not applicable, but really Maheims can have automaticity. And then WPW or concealed accessory pathways. And then finally, at the level of the ventricles, VT can be reentrant or automatic, and VF is generally automatic. Okay, so we're going to go into very brief general comments about treatment of arrhythmias. And throughout the entire year, we'll go over lots and lots of examples of arrhythmias and how to manage them. Okay, so in terms of treatment, drug therapy is generally effective for most forms of SVT. And there are some patients in whom drug therapy is used as their definitive and chronic therapy. And these include commonly used agents are digoxin, procainamide, beta blockers, verapamil, sotalol, amiodarone, and flecainide. And throughout the year, we're going to go over each of these agents in greater detail. When we're talking about acute therapy, particularly for SVT, adenosine is typically used, which we all know causes transient AV blockade, and it's particularly useful for AV reciprocating tachycardias such as orthodromic reentry or AV nodal reentrant tachycardia, which, as you know from last week, are the two most common forms of SVT in children, accounting for probably about 95% of all tachycardia. IV verapamil is also a very reasonable agent, and until the time that adenosine was commercially available, which was only the late 1980s, IV verapamil was the most commonly used agent to terminate SVT, and it's not used as commonly anymore because we have adenosine and because it has very potent negative inotropy. And it's also shown to be associated with cardiovascular collapse in infants. There's a literature from the early 1980s where IV verapamil was reported in a number of cases to cause cardiovascular collapse in babies. And so Generally speaking, IV verapamil should never be used in small infants, but in the past it was used quite routinely in older children who had SVT as a very effective mechanism. Part of the problem with IV verapamil is it comes as a fairly concentrated solution, and so you have to really dilute it a lot, and you have to give it very, very, very slowly, or else you will get cardiovascular collapse, or at least profound hypotension and bradycardia. In terms of chronic therapy, digoxin is not uncommonly used as an antiarrhythmic agent in infants. It is considered more old-fashioned. It's not a very strong arrhythmia medication, but it definitely has its place, particularly in patients in whom you might want to use it for two things, such as some inotropy as well as for antiarrhythmic properties. It can cause AV nodal slowing, which is one of the mechanisms by which it works. It also reduces the amount of atrial ectopy that patients with SVT have, and those are the two main mechanisms by which it clinically works to reduce the chances of SVT. Dosing is between 8 and 14 micrograms per kilo per day, divided BID, and for small infants premature, it's even lower. Beta blockers are a useful alternative antiarrhythmic agent, and probably in the present era is the most commonly used agent that we use for treatment of SVT in kids. Causes AV nodal slowing, also reduces atrial ectopy, though in a completely different manner. And it's the most commonly used agent is Inderal or propranolol. As a general rule, we would rather use this orally. I would say never give this IV. There are IV beta blockers such as esmolol, which we can talk about in the future, but Inderal is a very reasonable agent. It's probably the most commonly used one. It can be associated in small infants with low glucose levels, and so D-sticks should be monitored for the first 2 or 3 doses when initiating this therapy in small infants. And this is the reason why, if you make this diagnosis as an outpatient in a small infant, you have to typically admit the patient for observation and monitoring of blood glucose levels when patients are initiated on this therapy. And I didn't put it here, but the dosing range is usually 1 to 4 milligrams per kilogram per day. And actually, if you are a student of pharmacology, you would know that the half-life is very short, and so it really is supposed to be given Q6, but it's uncommon that we use it in a Q6 manner, mostly out of recognition of the fact that parents have trouble giving agents Q6, and so we usually dose at Q8 with the understanding that it will not be as effective. And some of you have seen that when we're having difficulty controlling an arrhythmia, like SVT in an infant, one of the first things we might do would be go from Q8 to Q6. When we're talking about older children, beta blockers are still used and are effective about 60 to 75% of the time, which isn't a particularly high efficacy, but because of the low side effect profile, they're commonly used at least as a first-line agent. And in most cases, in my experience, beta blockade is effective at minimum at reducing the number of episodes, or perhaps making them less fast, better tolerated. But generally speaking, beta blockers are not 100% efficacious, but because SVT in most patients is not life-threatening, it's a reasonable first step. Also, in children who are out of the newborn period and adolescents, the agent can normally be started as an outpatient, and so we don't have to worry about hypotension or proarrhythmia. It has a very good safety profile in terms of that. Calcium channel blockers have a similar efficacy to beta blockers. You don't see us using them as much, but they are pretty effective. Also have a low side effect profile. I'll remind everybody that we do not use calcium channel blockers in patients who have Wolff-Parkinson-White syndrome. We talked about this last week, how it can enhance accessory pathway conduction and potentially take low-risk pathways and make them high risk for sudden cardiac arrest. Digoxin is really pretty much not used anymore in older patients. predominantly because it's not an especially effective agent. I think in the past, and by that I mean long before I was a physician, people would use digoxin in an era when we didn't have as many other agents. But in the present era, I think dig is almost never used as a chronic antiarrhythmic agent in older children. And then when those simple agents like beta blockers and verapamil calcium channel blockers are ineffective, if we're going to use medical therapy, sotalol would be one of the more common agents that we would use. And I'll remind you that sotalol is a combination of both a class 3 agent as well as a potent beta blocker. So sometimes people think because it has that suffix of lol on it, just like propranolol or atenolol, that sotalol is just a beta blocker, but it is in fact a potassium channel blocking agent as well as a beta blocker, and is profoundly more effective in general as an antiarrhythmic agent. There is a somewhat high incidence of proarrhythmia seen in at least about 10% of patients in the literature. And so generally speaking, this is an agent that we would not start as an outpatient. We would typically start it as an inpatient. And if you listen to my podcast, there have been 1 or 2 articles we've reviewed where groups have at least posited the notion of starting sotalol as an outpatient in a select group of patients who have healthy hearts and normal function. But I think at the present era, it would be fair to say, at least in the United States, most of the time sotalol is started as an inpatient. Typically, we observe a patient for 48 hours because most patients who will have proarrhythmia will have it in the first 24 to 48 hours. And remember that sotalol prolongs the QT interval. Again, we're going to discuss all these agents at much greater length throughout the year. But because of that, anybody who has anything approaching a long QT should not be started on sotalol. Flecainide, which is a 1B agent, sodium channel blocking agent, is another very effective antiarrhythmic agent for certain forms of SVT. It also has a very high incidence of proarrhythmia, probably the highest of all the agents that we use routinely to take care of kids with tachycardia. And so it needs to be used carefully. And just like sotalol, generally speaking, at least in the United States, we would start this as an inpatient with 24 to 48 hours of observation, looking for proarrhythmia. Flecainide has a bad name because of the so-called CAST study. CAST study was a study performed in the early 1990s in adults who had coronary artery disease. At that time, there was surprisingly little information known about what agents were superior or inferior for patients who had coronary artery disease and were having arrhythmias. As you know, the most common sort of side effect of a heart attack is, or problem is, first, of course, dysfunction from myocardial injury. But what kills these patients usually is arrhythmia. So in the early days, 30, 40 years ago, cardiologists would just, kind of randomly choose agents. And if you were having a lot of arrhythmia, you were put on the bigger guns, such as flecainide. And the CAST study essentially showed that if you had coronary artery disease and you had ventricular ectopy and you were put on flecainide, your chances of dying were actually higher than if you were on nothing at all. And so flecainide is contraindicated in anybody who has coronary artery disease, and it got kind of a bad name as a result of this study. But in reality, it's a very safe agent in most young people who have healthy hearts, and we use it with some regularity. It's particularly hard, though, to dose in infants because it has to be made into a solution, and so that carries a lot of risks in terms of dosing. And then, of course, there's amiodarone. Amiodarone is also a class 3 agent, but they used to have these ads on the back of JAMA in the New England Journal saying it was the only agent that has all 4 von Williams classification effects, meaning it's a class 1, 2, 3, and 4 agent, but its predominant mechanism is class 3. It was actually initially introduced as a heart failure drug, and it was later discovered to not be particularly good for heart failure, but very good for prevention of arrhythmias. Generally speaking, it's a very effective agent. This next point is a very important one. It has an extremely long half-life of 45 days, possibly one of the longest half-lives of any agent for any type of medication. And that is the reason why when we start somebody on amiodarone, we typically have to load them for 7 to 14 days or longer. And interestingly, despite being a very, very potent antiarrhythmic agent, it has actually a very good track record of having a low incidence of proarrhythmia. And so amiodarone's a great agent for people who you're worried about that. The big issue with amiodarone for chronic therapy is that it has a very high side effect profile. Particularly can affect the lungs, resulting in potentially pulmonary fibrosis, which cannot be reversed. Can cause abnormalities in your liver function studies. It can affect your thyroid, causing either hyper or hypothyroidism. It can cause discoloration of your skin, particularly in the sun. And it's always important when you have patients on amiodarone to remind them of the critical importance of using aggressive sunscreen protection, particularly in the summertime, because sun can cause a very unusual blue discoloration of the skin if you're on amiodarone. Can affect your eye, mostly causes corneal microdeposits, which do not affect vision in any way, but very rarely can affect the retina. And so that's the reason why we generally recommend that ophthalmologists see patients who are on amiodarone, and it can cause diarrhea or other GI disturbances. But as we've learned this morning, drugs aren't a free ride. There are lots of side effects, as we just saw with amiodarone. There's always the concern of proarrhythmia. The other thing about drugs, which we always say to parents, is that they're not always effective, and it's very much trial and error. So sometimes you have one patient in whom an agent is exceedingly effective, and it's not effective at all in the next patient with the same exact arrhythmia. And so that's one of the very frustrating aspects of treating arrhythmias with drugs, is that particularly when you're admitting patients to the hospital to initiate these agents, is you don't even know when you're doing it if the patient is going to be helped by the medication. Most of the time they are, but not always. As is the case with all medical therapy, there's the issue of compliance. There's the issue of lifelong usage. And then finally, for certain conditions like Wolff-Parkinson-White syndrome, certain drugs may not actually reduce the risk of sudden death. For example, beta blockers, which are used in pediatrics not uncommonly in people with WPW. Some people actually think they might enhance the risk for sudden cardiac death. In fact, I think in the adult world, it's uncommon to actually use beta blockers in that setting, but for sure, they don't definitively work in all patients to reduce that risk. When we're talking about intra-atrial reentry, which we briefly discussed at the end of last week's talk, drug therapy is terrible. This is a long ago abstract, but this has been reproduced by others. But the bottom line is we're looking at the percentage freedom from recurrence of flutter in various antiarrhythmic agents if you've had congenital heart surgery. And, basically at 2 years, the best you can do is 38%, which is actually better than amiodarone or sotalol. So none of these therapies are a whole lot better than digoxin alone. So we very often will use antiarrhythmic agents to treat intra-atrial reentry, and when a person has their first episode, we'll start them on something, but I'm being honest in saying that for a lot of patients, these agents are not particularly effective. So you need to set expectations in those circumstances. And because of that, ablation has become more commonly advocated for people who have tachycardias. And obviously the advantage is that it is a potentially definitive therapy, and drug use is not required if the procedure is efficacious. We're going to talk a lot about ablation throughout the year, and all of the fellows are going to be participating in a large number of ablations between me and Barry. In terms of the technical considerations, most ablations require the placement of at least 4 or 5 catheters. So that means 4 or 5 central lines. And so we have a catheter going in the coronary sinus, one in the right ventricular apex, one in the right atrium, and then one at the area of the bundle of His, not to mention the ablation catheter. So a lot of catheters some labs will have as many as 2 or 3 cardiologists. Some of you who've worked with me see that we usually do it with me and Josie, a nurse practitioner. There's usually a nurse in the room, a CV tech. There's a lot of people involved. We're using computerized online analysis, both through a standard computer as well as electroanatomical mapping, which we'll go over briefly. We're using fluoroscopy to some degree, although less in the present era, but I think it'd be fair to say most labs do still use fluoroscopy, at least in a limited manner. And then, of course, there's a program stimulator. So a lot of equipment, a lot of people, very involved procedure. However, extremely effective. And this is just a very simple example of somebody who has ablation of ectopic atrial tachycardia. The energy is turned on, and what we see is acceleration in the tachycardia rate followed by sinus rhythm. It's just a simple example. And this is another example of somebody who is having an ablation, and they're in V-pace rhythm, and radiofrequency energy is turned on, and we see a change in the pattern of retrograde conduction within just less than 1 second of turning radiofrequency energy on. So this is something we always like to see. Now, radiofrequency ablation is extremely effective. Depending on the arrhythmia, it can be close to 100% efficacy. This is an old slide of showing the data reported basically 25 years ago from Boston Children's. Even then, they were reporting success rates mostly in the 90 to 95% range for ablation of most forms of SVT. And at the time I prepared these slides a couple of years ago, at Monty, we had a 94% success rate. And I think that's fairly reflective of what we're seeing now. So ablation is good. It's not 100%. We still have a ways to go in that regard. We still have our frustrating cases, but in general, it's a very effective therapy for most common forms of SVT. And that's probably the most strong rationale for advocating for it in most young people who have SVT. But there are risks associated with ablation, and these are all the normal cath risks, some of which we discussed in cath conference on Thursday last week, including bleeding, stroke, infection, and more serious complications like death, ventricular dysfunction, typically due to coronary injury, stroke, or cardiac perforation. At the time of that Boston study, they reported about a 1% incidence of these sort of very serious complications. I think in the present era, that incidence is lower, but it is certainly not zero. And, I'm in a debate at the World Congress on whether or not people who are asymptomatic WPW patients should all be studied and ultimately ablated. And, one of the things that I think are very undervalued is this complication rate. And, complication in any patient is terrible. We would never want to see any complications. But as many of us know, anyone who says they do procedures and never has a complication does not do procedures. And unfortunately, there's always a risk for complications. And so that fact has to be weighed against the potential benefit in any individual patient. When we're talking about Fontan patients, the efficacy is quite a bit less good. And there are many reasons for this when we're talking about ablating flutter. These are some old-time angiograms of Fontan's, but we see how gigantic the right atrium can be in some of these patients. And so you have a tremendous ground to cover. The arrhythmia the reentrant loop is not in the same place at any 2 patients. So identifying where it is can be very challenging. And then there are a lot of issues related to the thickness of the atrium. Patients who've had a Fontan can often have a very thick right atrium. This is mostly talking about lateral tunnel or old style Fontans, but even patients who have extracardiac Fontans carry the additional complication of having to get into the heart, which is not so easy and requires sometimes a transbaffle puncture, which is not without risk. So a lot of potential reasons why it's very hard to ablate these patients. And data for the standard RF ablation of IART have been very poor, and that's about 50% arrhythmia free at 2 years follow-up. Now, these are old data. There are newer data suggesting it's more in the range of about 75 to 80% arrhythmia free at 2 year follow-up, but I think we would all see that this is substantially less good than it is for standard SVTs. But these numbers are still a whole lot better than the numbers that I showed you for drug therapy, where, as you see, the efficacy rates at 2 years are well below 50%. And this is the rationale for proceeding on. But we have, come up with a number of newer techniques in the last decade or two that have helped. And the first is the use of electroanatomical mapping systems such as CARTO. St. Jude makes an alternative product. And the benefit of CARTO is that we can both record the location of the catheter in space as well as the signal. And so it allows us the opportunity to on the same map, put both timing and location. And the way CARTO works is that signals that are earlier are indicated with the hotter colors, such as red, and the cooler colors are late. And so presumably the area of interest would be in an area closer to the red area. So use of 3D mapping has markedly improved not only the management of these complex intra-atrial reentrant arrhythmias, but as most of you know, we are now using it routinely in SVT ablations. And actually, it was my group and others that have demonstrated in the past enhanced success rates for SVT ablation using CARTO, as well as marked reductions in radiation, because we can see the catheters in real time using CARTO. And that has, in our last study we published on this about 7 or 8 years ago, we showed that the radiation dose associated with the addition of CARTO to standard SVT ablations dropped the dose about 10-fold, actually. We also have cryocatheters, which has been a big plus in the field of electrophysiology, and that they allow for smaller lesions. And the most important benefit of cryo is that it is at least temporarily reversible, meaning that if you turn on the cryo energy and you start to see something you don't like, most importantly, heart block, because you're ablating near to a critical structure, if you notice it early enough and you turn off the cryo within a few seconds, there will be reversibility of the injury in the vast majority of cases. And some families have asked us, or cardiology fellows have asked, well, why don't we use it all the time? First of all, it's complicated to set up. Any of you have seen us do it. It's always a pain in the neck. But the most important reason that we don't use cryo is routinely all the time, even though it does have this nice benefit of reversibility, is that it does not work as well. It makes a smaller lesion, and the recurrence rate is probably, in most honest papers, in the range of about 5% higher than it is with standard radiofrequency energy. So when we're in areas that are very dicey, where we're very worried about the AV node, cryo is not an unreasonable thing to try, but understanding that the recurrence rate is a little higher. More recently, we have newer catheter technology. First of all, we have catheters that have irrigation. A lot of you have seen us use those. Barry uses this with some regularity. And the advantage of an irrigated catheter is that it actually allows for greater delivery of power with a deeper radiofrequency and wider radiofrequency lesion than can be achieved with standard RF. These catheters were largely developed for the treatment of serious arrhythmias like ventricular tachycardia, where you need to make deeper lesions in adults who've had myocardial infarctions and have reentrant arrhythmias. But they have been used for other purposes in pediatric EP, I think it'd be fair to say most pediatric electrophysiologists use it mostly for the treatment of people who have IART, single ventricle Fontan ablations, but some electrophysiologists are using them increasingly for other indications. And then the other newer technology just in the last 4 to 5 years is the integration of contact force into the catheter. So the tip of the catheter, the ablation catheter, actually has an ability to measure the amount of force in grams that the catheter is exerting on the endocardium. And this allows the electrophysiologist to know that they are making contact with the tissue. And it's been demonstrated by the company in multiple experiments that if you have a minimum of about 4 to 6 grams of contact force, that you are actually touching the myocardium and you're going to make a more effective lesion. And this has been particularly beneficial in the Fontan patients, where sometimes if they have a very large atrium, you might not even realize that you're not touching the heart. In regular standard SVT ablations, that is still the case as well. For example, in AV nodal reentry, we often make anatomical burns in the lowest third of Koch's triangle, but we don't see effect. And probably the answer to that is in part because we're not actually touching the myocardium adequately. This catheter, shall we say, keeps you honest, makes you realize whether you are or not, in fact, touching the heart with an adequate force to deliver energy to make an actual lesion. And so, we've been refining our newer mapping strategies. There's now surgical approaches to reduce IART as well as to treat it. And there's a whole literature on doing Fontan redos, where surgeons will surgically address these IART circuits. Although I think in the present era, our catheter-based technologies are improving. We've talked about newer catheter design to lower cath-related risks of ablation, such as using cryocatheters, irrigated tip catheters, and contact force. And of course, we're using markedly lower fluoro protocols as well as 3D electroanatomical maps to reduce our exposure to ionizing radiation. And so you all understand, most of our ablations are at our hospital now are in the range of less than 10 milligray. Most of them are under 5 milligray. An ablation in the past, prior to the integration of 3D electroanatomical mapping as well as lower fluoro protocols, would routinely be 400 to 600 milligray of radiation. Because remember that when we ablate, in order to make sure the catheter is not moving, we would routinely stay on fluoroscopy the entire time. And so since most radiofrequency applications are a minute in duration, and since we do, typically 3 to 5 applications in a typical patient, we're basically would have a minimum of 5 minutes of extra fluoro time to do the ablation part. And in difficult cases, it could be 30 or 40 minutes of additional fluoroscopy time. Add to that the fact that we were using higher frame rates and higher doses per frame. It's not hard to imagine why the dose that we're giving is literally 1,000-fold less than it was even 10 or 15 years ago when we do ablation. So that's a sort of quick and dirty review of arrhythmia management in general. We're going to talk about all of these topics in greater detail as the year progresses, but I think it's sort of a good starting point for everybody, so we're all on the same page going into the year. Does anybody have any questions about any of this? Okay.
Yeah, actually, just one question about the reluctance to use IV propranolol.
Yep. Okay. What is the question, Dave?
What's the issue with? I know we have IV propranolol. Is it that it's a hypotension issue, or what's the?
Yes, that's basically it. I guess maybe I was being a bit dogmatic about it. Some people do use it, but I think the bottom line is in my experience, it can cause substantial hypotension, and it's not uncommon that a dose mistake is made, where a patient gets too high of a dose. It has to be adjusted when it's given IV. I would make the argument that if you need IV propranolol, if you need beta blocker that quickly, you probably need something else. And quite frankly, if you need IV propranolol, I would say if you really want to give an IV beta blocker, I would use esmolol, which has a much higher safety record in patients, also has a much shorter half-life, so that if you're not pleased with the effect, I think the half-life is, I mean, Ivana could tell us this, but I think it's in the range of 1 or 2 minutes. So it's gone fairly quickly. I would say if you feel the need to give IV beta blockers, I would use esmolol, or else I'd use something else. Truthfully, the main reason I don't like it is because I've seen too many people get it dosed improperly and have a problem as a result of it. I don't even know the dose of IV propranolol. I'd have to look it up, but it is not the same as the oral dose. Okay, I hope this wasn't too basic for everybody, but I think it's a good idea to start at the start, and then we can get more complicated as time passes on. So I will see you all next week on Monday for the next EP conference. Have a great day, everybody.
Thank you, Dr. Pass.
Bye-bye now.